Welcome to this tutorial on performing a suprapatellar recess injection under ultrasound guidance. This technique is often used for knee osteoarthritis, gout, or inflammatory arthritis, which all frequently present with suprapatellar effusions. The suprapatellar bursa communicates with the knee joint in about 85% of individuals, making it an ideal injection site for targeting inflamed synovial structures and nerve endings. You want to start by positioning the patient supine or semi-recumbent with the knee extended. Place the ultrasound machine on the opposite side, and it's usually best to do this procedure lateral to medial. Use a high-frequency linear transducer in musculoskeletal mode and scan transversely over the patella, then move proximally. You'll begin to visualize from superficial to deep the skin, subcutaneous fat, quadriceps tendon, suprapatellar fat pad, the effusion, prefemoral fat pad, and the femur. Prior to obtaining consent, make sure to ask the patient about prior surgeries to that knee and if they had an injection in that knee before. If there has been an injection to that knee in the last 3 months, that is a contraindication to performing this procedure, as frequent injections may cause chondrotoxicity and destruction of that capsule. If someone has had prior surgeries to that knee, we may need prior approval from the orthopedic surgeon, depending on how far out that surgery was. As stated before, our positioning is going to be supine or semi-recumbent. Our approach is lateral to medial. We're going to be using high-frequency linear probe in the MSK settings. And our ultrasound machine is on the opposite side of the bed. We begin by scanning over the patella in our transverse view and moving proximally. We're going to mark the depth of the effusion. For example, in this video, this patient's effusion is about 2 centimeters deep. So that means we'll have to insert that needle at the same depth from the skin line when we begin our approach to avoid penetrating the quadriceps tendon or contacting the femur. If fluid analysis is needed, you will need a larger syringe to begin with. Using sterile technique, draw up your anesthetic, optionally mixed with steroids, and also draw up your anesthetic in a different syringe for the skin wheel. Begin by creating a small skin wheel at the injection site. Then using a 20 to 25 gauge 1.5 inch needle, insert the needle in plane, lateral to medial under continuous ultrasound guidance parallel to the joint line. For our patient in this video, the effusion was 2 centimeters deep, so we began our approach 2 centimeters below the skin line. If fluid analysis is needed, aspirate first with a large syringe, then leave the needle in place and switch to your medication syringe. Always leave a pocket of fluid to inject into. Once you've switched to your injection syringe, administer the medication once needle placement is confirmed. Afterwards, apply gauze or bandage and reassess the patient in 30 minutes. While this list is not exhaustive, it does represent common indications encountered in the emergency room. I do want to make note of prior hardware again. Injecting medications into a patient with post-surgical knee pain requires approval from the surgeon. It is common practice for us to avoid injecting into joints with prior hardware or those that have recently undergone surgery. Please use caution when using steroids in uncontrolled diabetics. Here are some contraindications and complications to be on the lookout for. Here's our anesthetic and dosing of corticosteroids. Here's a little cheat sheet for quick reference. Just remember this technique offers both therapeutic and diagnostic benefits. And remember, precision, sterility, and patient safety are key.